Lauren. I am one of the dietitians working at UNC in the pediatric GI clinic, and I work really closely with the IBD physicians, and so end up seeing quite a bit of IBD in our clinic. And so today, what I wanted to do was kind of touch on the role of the dietitian in IBD clinic and what that kind of looks like, what I'm really doing throughout the day. And so the objectives for this presentation are to first identify the role of the RD in IBD care, and then I wanted to walk through an IBD-focused nutrition assessment, kind of talk about what that looks like, what dietitians do, but also what dietitians do when patients have IBD more specifically. And so I'll go through some assessment questions that I frequently ask, lab work that I'm looking at, drug-nutrient interactions that I take into consideration, touch on growth a bit, and then some of the therapeutic diets. So what is the role of the RD in IBD clinic? There's a few things that I'm always thinking about when I go to assess patients. The first is, we're always looking at growth status and trying to identify those that may be at nutritional risk. And so that includes patients that are underweight or may have recently had a significant degree of weight loss. This could include patients that are overweight, have had a significant degree of weight gain recently, those with obesity, or those who have struggled with childhood obesity, and then patients that have micronutrient deficiencies as well. I'm also, when I'm evaluating patients, kind of getting an understanding of their diet and the adequacy of their macronutrient intake and micronutrient intake. So asking questions about what foods they eat, when they eat them, what a typical day of eating looks like for them, to get that kind of data, but also probing more about the patient's thoughts around food and their relationship with food. And this is extra important for those that have IBD, because what we often see is, kids have had poor, experiences eating a certain food. They have foods that they find are triggers. If they're in a flare, like was mentioned earlier, fiber becomes more difficult to tolerate. And so a lot of our patients have a lot of negative experiences with foods. And over time, this can lead to restricting and sometimes can kind of lead to disordered eating as well. I'm also looking at the social and financial factors that influence diet. So trying to probe families about, do they feel like they have enough money at home to buy food? Are there programs that they are, involved in, SNAP, WIC, that's helping them to purchase food and have enough food at home for the family? And then kind of the last part of my job and role as a dietitian is to provide nutrition counseling, diet support, guidance, and education. And this looks different for every patient, but often what I'm talking about can be a general healthy diet. We can be talking about therapeutic diets. So that would include exclusive enteral nutrition, Crohn's disease exclusion diet, or a specific carbohydrate diet if patients and families are wanting to try to manage disease with diet. We can talk about that with them. I'm often talking about bone health as well, since working in pediatrics, and patients who are taking steroids as well have higher needs of calcium and vitamin D. And then also talking about navigating diet with restrictions, food allergies, and trigger foods, et cetera. And so kind of like I mentioned earlier, many patients find themselves restricting gluten or restricting dairy because they feel that it makes them feel worse. And so just trying to counsel, educate on what a healthy diet looks like when you're excluding some of these food groups to make sure that they have a well-rounded diet that's meeting all of their macronutrient and micronutrient needs. So what my assessment falls into kind of 4 categories. And what I'll do is I'll first get a nutrition history, kind of compose a little paragraph of my nutrition assessment, make a plan or an intervention for the patient, and then touch on points and areas that I want to monitor and evaluate with the patient. And so I'm going to go through these 4 parts of my assessment, and I'm going to use a case study to kind of guide us through the whole assessment, make it a bit easier to understand. And so this is the patient introduction. This was a patient that I saw in clinic with one of our IBD physicians. The patient was a 16-year-old male seen for medical nutrition therapy for the evaluation of growth and oral intake. And so this patient was also seen by the physician for his Crohn's. He had never been seen by UNC, or he had never been seen at UNC prior to coming to us. So he was new to nutrition services, and he was new to the GI team today. He was coming in for a second opinion. He had a history of Crohn's disease, ileolocation, inflammatory phenotype that was diagnosed a few months earlier in Florida. He initially started having symptoms in November 2023. I think we saw him around about 2 or 4 months later. The patient and the family both had a very strong interest in dietary therapy for IBD, and he was currently on a modified Crohn's disease exclusion diet. And so the family kind of took it upon themselves to do their own research, came across the Crohn's disease exclusion diet, and modified it a bit to their liking. The diet, and they kind of changed the diet to be mostly plant-based, and the patient was supplementing with nutritional shakes that were actually homemade. Usually we see with this diet that patients are taking nutrition supplements that we know are nutritionally complete. And so this was something that was definitely on my mind with this patient, is that the family had found their own protein powder from the store and kind of created their own nutritional shakes. At the time that I saw him, his disease activity was mild, and I got that information from the physician, and he was not taking any medications. And so started my nutrition history with an intake assessment for him. And my intake assessment kind of goes through the patient's usual intake. I can get that by just asking, what does a typical day look like? Or if that's not giving me the information I need, I'll try to ask patients what they ate the day before if they remembered. Also do a food frequency questionnaire, which asks, how many servings of fruit do you think you have per day on average, vegetables, etc. Ask about any oral supplements, nutritional shakes that patients are taking, any vitamins, minerals they're taking, any restrictions they have, any history of therapeutic diets that they've been on or tried, any trigger foods, any GI issues or complaints that they have, their thoughts around eating, and their exercise habits as well. And so this patient, I was able to get a 24-hour recall. And so the day prior, he had consumed 3 egg hoppers, Sam bowl, which was a combination of rice and coconut curry. He didn't seem to be a big snacker, is more so like a 3 meals a day kind of person. He had lunch at 12, gluten-free pasta, tomato sauce with chickpeas, olive oil, zucchini, spinach. He noted that he'll sometimes have a granola bar or fruit for snack if he's hungry. Dinner was rice, lentils, beets, olive oil. And he noted that he usually aims to drink around 40 ounces of water a day. And then he was supplementing with those homemade nutritional shakes that parents were making. And so on average, family and patient reported that he has at least 4 servings of fruit a day, at least 4 vegetables. He does not eat dairy, but he was having 3 servings a day of dairy alternatives, and using the protein powder from the shakes. Proteins, was not eating any meat, but was getting sources of protein from plant-based sources like chickpeas, lentils, peanut butter, and then he did have eggs as well. So he wasn't completely plant-based. And then grains and starches reported at least 6 servings a day as well. Lots of rice, and gluten-free alternatives. The family actually the family had been tracking his intake, calorie intake and food intake. So they actually had good information on his diet. So I was able to look at a few days of his eating history, and mom calculated his average intake to come out to around 4,000 calories. So this was really good information for me to have. This is a patient that was really doing a great job with his diet, considering the diet he was on. He was also a competitive tennis player, practicing on average 4 hours a day. These practices included a combination of weight training, cardio, and then tennis drills. He did not have any GI issues. Reported that he was going to the bathroom twice a day. Consistency was formed. No other concerns there. He had reported food allergies to dairy, and he had noted that he felt dairy was a trigger as well for his Crohn's. He began avoiding gluten, dairy, and refined sugars after his diagnosis of IBD. The parents did not eat meat. The patient used to eat chicken nuggets from fast food restaurants prior to the IBD diagnosis, but once he was diagnosed, he stopped that. And he didn't have many specific food dislikes at all. He was not a picky eater, happy to eat mostly anything. And he did have an interest in having a healthy diet, and eating well for tennis. He had a willingness to try new foods. He did have a preference for fast food before, but kind of, after his diagnosis was, like I said, very motivated to be healthy and have a healthy diet. His appetite and energy levels were all good as well. So that was kind of the intake assessment history that I got. And then another part of the nutrition history is looking at his anthropometrics, weight, height, BMI, ideal body weight, and all those factors. And so we didn't have a lot of growth history for this patient since he was new to us, coming in for a second opinion. But we had one data point here. This was his length for age at the 37th percentile, weight for age at the 29th percentile, and then his BMI for age was coming out around the 30th percentile. And so I asked about any weight changes that the patient had had. He had not had any recent weight loss, weight gain. And family seemed to think that this had been a very typical weight for him his whole life. So no major changes to his weight there. From that assessment, kind of gathering his intake, no changes to his weight, I was able to kind of classify him as not meeting criteria for malnutrition. But this is a part of our assessment as dietitians as well, is to assess what patients are eating, and assess their weight changes and their growth and identify if they are at malnutrition risk. And I have attached some photos here about what this criteria looks like. And so in the bottom left photo, the primary indicators that we're looking at when there's only a single data point available, which is what we had for this patient, is that we're looking at BMI for age, Z-score. If it is from -1 to -1.9, that'll classify a patient as mildly malnourished, and then so on, -2 to -2.9, moderately, -3 or less is severe. We can also look at their height for age, and mid-upper arm circumference. Our patient was at a Z-score of -0.5 with BMI for age percentile at 29 percentile. So he did not meet criteria. He also, was eating quite a bit of food, around 4,000 calories a day. So I did not think he met criteria. Other things that we can look at to identify if patients meet criteria is, again, their intake, weight gain velocity, if patients are less than 2 years old, and any weight loss that patients have had as well. And so I documented in the chart that there were no weight changes. This was also a new patient, so we didn't have any data for that. I calculated his ideal body weight to come out to around 58 kilograms. for BMI for age around the 25th percentile. He was 59 kilograms. I did not perform a nutrition-focused physical exam due to the lack of malnutrition risk factors, and he did not meet criteria for malnutrition. The next part of the assessment involves calculating the patient's energy, protein, fluid, fiber, calcium, and iron needs as well, so that I have a reference and something to compare a patient's diet to. So what we use to calculate these, energy goals and protein goals, and we have equations that we use. We have equations for children who are of a healthy BMI, and we have different equations that we use for those who have overweight BMI. So the equation I used for this patient was the estimated energy requirements for boys aged 9 to 18 with healthy BMI. The equation involves a physical activity coefficient. And so it takes into consideration a patient's activity level, which is really nice. The coefficient that I used for this patient was 1.42, which was the number used for someone who's considered very active. And very active includes typical daily living activities, plus at least 60 minutes of daily moderate activity, plus an additional 60 of vigorous activity, or just 120 minutes total of moderate activity. And so he had let me know he was a very competitive tennis player, exercising for about 4 hours a day. So he was a good fit for this coefficient of 1.42. And his calorie needs, after plugging all these numbers in, his age, his weight, his height, and this activity level, came out to around 68 calories per kilogram, which was fallen around 4,000 a day, which is what he had been getting. So that was good news to hear. His protein needs were increased for his level of activity. For his age, it typically would fall around 0.8 grams per kilogram, but considering that he was an athlete and also considering that he did have mild disease, per the physician, I set his protein needs a little bit higher. Fluid needs, I used just a typical calculation. Because he's an athlete, they're probably a bit higher, but this was just a minimum number that I came up with. And then fiber needs, I just referenced the dietary guidelines for age, so 25 grams a day. I will also screen for any, food safety, access concerns. I get information about the grocery shopping, who does it, is there transportation, and any supplemental resources that family may be using. In this case, there were no issues with food safety and access. Mom primarily did most of the grocery shopping, and family did not qualify for SNAP, WIC, or any additional programs. So now kind of moving on to the next part of our nutrition history, which is looking at the biochemical data, lab tests, and procedures. And so primarily what I'm kind of looking at is nutrition-related labs, endoscopies, colonoscopy results, biopsy results, and any past history of surgeries or any potential upcoming surgeries that a patient may be having. And so these are primarily nutrition-related labs that I am looking at. And so we want to be very mindful of iron, vitamin D, B12, folate, and zinc, primarily with IBD. Iron is always drawn at diagnosis and annually at a minimum. If a patient has low intake of iron as well, I can suggest that it's drawn. But the physicians, they're always great about drawing these labs. And so with most patients, they are drawn annually at minimum, but if hemoglobin and some of these iron labs have been frequently coming back low, we will draw them more often. The treatment for this is initiate with diet changes and also an iron supplement. So ferrous sulfate starting at 3 milligrams per kilogram per day of elemental iron. We want to give in the morning or between meals, and dairy should be avoided for 1 hour before and 2 hours after taking. Vitamin D, we're checking twice yearly for maintenance or every 2 to 3 months if low. We can treat this with 50,000 IUs weekly for 8 weeks of vitamin D or 2,000 to 4,000 IUs daily. B12 and folate, we're usually checking these if there are risk factors, and risk factors would include significant ileal disease, active inflammation, ileal resection. If patients are on a vegan diet, we'll check B12. And then same thing with folate, if there's severe small bowel disease, or if a patient has been taking sulfasalazine and methotrexate without folic acid supplementation, we'll also check those levels as well. And with zinc, we're also checking that primarily with risk factors. So severe small bowel disease, resection, if the patient's having severe diarrhea, or if there's low alk phos and taste changes, we'll check for that. And treatment would be 1 milligram per kilogram up to 50 milligrams daily. So with our patient in this case, this was his lab work that we were looking at, and this was coming from his physician in Florida that he had seen. So no labs had been drawn from us. And so some of the labs that stood out to me, primarily, I was looking at his hemoglobin, which had been normal in February and then normal again in April. And so that was reassuring. Vitamin D had been drawn in February as well, and that was normal. Calprotectin had been decreasing since the patient had started this diet. And so the physician recommended clinic visits every 3 months with labs and calprotectin, as well as follow-up scopes in 1 year. If symptoms worsened or calprotectin was rising, repeat scopes may have been needed sooner. So really nothing jarring about these labs at all. Nutrition labs looked good, and calprotectin had been falling on the modified diet that the patient was on. Looking at the surgical pathology, there was some patchy active chronic enteritis, and based on this data, the physician classified this patient's Crohn's disease as ileal location, inflammatory phenotype with mild disease activity. Another part of the history is looking at the medications that a patient's on and any drug-nutrient interactions, and medications that may affect appetite as well. Our patient was on no medications, so this was not really of interest, or didn't really apply in this case. But often what is on my mind when I'm seeing patients with IBD is looking at the medications that they're on, specifically methotrexate, sulfasalazine. If patients are on these medications, they need to supplement with 1 to 2 milligrams of folic acid daily. If a patient is on high-dose steroids, they need to be supplementing with calcium and vitamin D. And then I'm also considering medications that may affect patient's appetite, including periactin, an appetite stimulant, which can make patients have a larger appetite. And then even sometimes anti-anxiety or antidepressants will affect a patient's eating behaviors. And if they are someone that has been really anxious and their anxiety has kind of limited their intake, I can sometimes see that starting these antidepressants or anti-anxiety medications can help with the eating. And then I also think it's a good idea just to keep in mind that patients who are depressed, depression can always affect our intake and our appetite and what we're eating. So these are just things that I like to be mindful of. And so after gathering all my history, I provided a brief summary of the findings. And so this patient was meeting goals for growth, BMI for age was appropriate, calorie and protein needs were increased for his level of activity, and he was still meeting these needs despite the massive increase. He has a history of Crohn's disease, ileal location, inflammatory phenotype, disease activity is mild, the patient and family have a strong interest in dietary therapy. His disease was being managed on the modified Crohn's disease exclusion diet that was mostly plant-based with some nutritional supplementation via the homemade shakes. The greatest modification that this family made was that chicken had been substituted with lentils and beans. They had a strong preference for a plant-based diet. On this diet, calprotectin had decreased from 941 to 300, and the patient and the family were both interested in continuing this diet. And I made sure to check that with the patient as well. And I think that's an important part of the assessment as well, is because sometimes we'll see, especially in the pediatric world, that families would really like to push diet therapy and the kids are not always the most excited about that. In this case, the patient was very much on board and wanted to do this. And so I was also supportive and on board if that's what they wanted. So considering that, this patient was overall feeling fine, labs were improving, he's maintaining a healthy BMI and a healthy lifestyle, I was okay with continuing the Crohn's disease exclusion diet with the modifications that they had made. I provided some education, which I'll get into in the next slide, about the diet, and we discussed that the patient could transition to following a phase 3 diet as a maintenance therapy if it was continuing to manage his disease. I also recommended drawing B12 with patient's next set of labs. He wasn't completely vegan. He was eating eggs almost daily, but it was mostly plant-based. So I felt it would be wise just to check that level. Also, the nutritional, usually on patients on the Crohn's disease exclusion diet, they're receiving about 50% of their calorie needs from nutritional shakes. And those nutritional shakes are complete and will have B12 in them. And so that's not usually a concern. But in this case, the family had found a protein powder online. I did not find much information on whether or not this protein powder was complete. I was able to see that it had iron and a little bit of calcium, but the label did not provide information on other micronutrients. And so I wanted just to double check the B12. And so next part of the overall assessment is the intervention in the plan. And so, like I said, we did a lot of education on the Crohn's disease exclusion diet with this family. They had already done their own research, and parents were both physicians. And so they were very knowledgeable and felt very confident and happy with the choice that they had made. But we went through a little bit, I just, provided a little bit more education and talked about the diet a bit more and provided some handouts for them about the different phases. So my instructions for this patient were that it was okay to continue the modified Crohn's disease exclusion diet phase 2. Handouts were provided. I provided protein goals for this patient, considering he's an athlete. His protein goals came out to 80 to 100 grams per day. Provided a goal for calories, 4,000 calories a day. And then follow-up will occur as needed with GI. The physician recommended clinic visits every 3 months with labs and calprotectin. And so I would be able to check in at the same day, same time as the physician as well. And so this is the Crohn's disease exclusion diet, which I wanted to get into if I have time. This is one of the therapeutic diets that has been shown to induce remission for some patients. And what this diet essentially is doing is it's trying to starve certain gut bacteria and allow other beneficial bacteria to grow. And the idea is that doing this will in some way help the inflammation in the gut and reduce calprotectin levels, reduce inflammation, and help the patient get into remission. So the diet is split up into 3 phases. This is the first phase, where 50% of your intake is going to come from nutritionally complete shakes. And so in this case, the family had been making their own shakes with a gluten-free vegan protein powder that they had found, and then they were blending fruits, vegetables that were allowed on this phase into the smoothies. On this first phase, there are mandatory foods that you're required to eat every day, and that includes chicken, 2 eggs, 2 potatoes, 2 bananas, 1 apple, and then you have these additional allowed foods that you're also able to eat. Again, this family wasn't following this, strict and to the T. They had substituted the chicken for lentils. The phase 2 diet, we increase the amount of allowed foods on this diet, and the amount of calories and protein that you're taking from the nutritional shakes, that's also decreased to about 25% of your daily goal. And so on phase 2, you're able to eat some additional foods. Whole grain bread, you're able to introduce in lentils, beans, chickpeas, quinoa, oatmeal, some additional vegetables, and nuts. And so this is the phase that the patient had come to me on. And so he was doing well on this. These are the disallowed foods, so foods that are not allowed at all on this phase. And so this includes any processed meats, red meat, pork, soy products, dairy products, wheat products, aside from the 1 slice of bread, dried fruits, certain vegetables, kale, asparagus, artichokes, condiments, any sodas, very sugary beverages, any processed candies, processed cookies, essentially junk foods in general, all disallowed on this phase. Phase 3 is the phase that we can actually, if the diet has been working for a patient, we can try to maintain phase 3 as a maintenance phase to manage the Crohn's. And so patient wasn't necessarily on this phase of the diet yet, but this was the conversation that I had with them, that if they wanted to continue to liberalize his diet, that they could choose to do so, and we could kind of monitor labs and see if this was working to keep him in remission. So on this phase of the diet, there are no longer any mandatory foods. They have liberalized even more to include some additional allowed foods, including other parts of chicken. Still wanted to avoid skin, fatty parts of the meat. There are some disallowed foods at all times still on this phase. Raw celery, large amounts of kale, persimmons, pomegranates, very, very processed foods like frozen donuts, processed meats, fast foods, fried foods, etc. And you have a little bit more leeway on the weekends, and to have some almost cheat days is kind of what they consider it as. And so you're able to have 1 free home cooked breakfast, 1 free home cooked meal that can include bread, cheese, some of these foods that are usually not allowed. Or if you want to eat out, you can choose to kind of substitute your 2 weekend days for 1 meal out at a restaurant. And then for the rest of the week, you would go back to following the phase 3 diet. And last part of the assessment is kind of looking at things that I would like to monitor and evaluate for the patient. And so our goals were kind of to avoid any known or suspected food intolerance or diet-related triggers of symptoms. I wanted to make sure he was able to meet his energy, protein needs to support normal growth and development. And want to make sure and check in on the fact that he's able to eat a variety of foods from all food groups to avoid deficiencies. I want him to maintain his current growth trend at around the 25th percentiles. That sounds like that's what had been typical for him and a healthy weight for him. And another one of our goals specific to this patient was to manage disease with diet.